PRP and stem cell therapy are increasingly becoming excellent treatment options for orthopedic conditions. We've seen incredible success using orthobiologics in professional and collegiate athletes, and are now using it to treat weekend warriors, the industrial athlete, and anyone else who has painful orthopedic conditions. This video will explore why orthobiologic treatment is taking over cortisone injections as the treatment of choice in sports medicine. I'll explain why and how platelet-rich plasma works, as well as review the latest clinical trial data supporting the use of orthobiologics. Let's get started. Hey everyone, Dr. Jeff Peng here. Now, if this is the first time you're watching one of my videos, my goal is to help each and every one of you live an active and healthy lifestyle. So if that's something you're interested in, please consider subscribing to my channel. I often give lectures to family medicine doctors in training, sports medicine specialists in training, and other practicing physicians. The following is a talk discussing PRP and stem cells and the use of orthobiologics in sports medicine. Okay, so this talk is to discuss the use of PRP or platelet-rich plasma as well as stem cells in the use of sports medicine. It's very quickly becoming our treatment option of choice in professional as well as collegiate athletes. And the goal of this talk is to discuss why, right? And to kind of frame why we are switching to orthobiologics, we want to first discuss the use of steroid injections. So cortisone injections or steroid injections, the thought behind it is to use the anti-inflammatory effects of corticosteroids to treat any type of inflammatory or painful condition, right? And so injections have quickly become the gold standard for pain control, right? If ibuprofen or Aleve or Tylenol, none of that is controlling people's pain, and they can't do exercise therapy or physical therapy because, well, it hurts too much to do it. Well, then we quickly offer a cortisone injection. Let's try to decrease their pain so that they can get back doing exercise therapy. And so for the longest time, this has actually been our gold standard, right? When we have our treatment algorithms, well, if they're not doing well, let's offer them a cortisone injection and, hope for the best, right? So the question is, should cortisone injections actually be part of the algorithm? And should it be our default gold standard? So this study was published in the New England Journal of Medicine. This was just 2 years ago. Physical therapy versus glucocorticoid injection, which is a steroid injection, for the treatment of arthritis of the knee. And so they compared physical therapy, which is 8 sessions, about 4 weeks of physical therapy, or steroid injections. And they can get steroid injections up to 3 times a year. And what they found was that patients with arthritis of the knee who underwent physical therapy had less pain and functional disability at 1 year than patients who received an intra-articular glucocorticoid injection. So steroid injections, they're actually inferior to physical therapy or exercise therapy. And so, when we start talking about, should cortisone injections actually be our gold standard for pain control? Well, you have pretty good data that says exercise therapy is superior. Now, what about side effects? There's actually quite robust evidence of long-term negative effects of corticosteroid injections. And I want to kind of frame this in terms of steroid having negative effects affecting joints, as well as steroid having negative effects affecting soft tissues such as tendons. So the study was published in JAMA a few years ago. Effective intra-articular triamcinolone, which is a steroid injection, versus saline on knee cartilage volume and pain in patients with knee arthritis. And what they found was, among patients with symptomatic knee arthritis, 2 years of intra-articular steroid compared with intra-articular saline or a placebo resulted in significantly greater cartilage volume loss and no significant difference in knee pain. The authors go on to conclude these findings do not support the treatment of steroid injections for patients with symptomatic knee arthritis. So not only is cortisone not superior to exercise therapy or physical therapy, steroids actually increase the risk of developing worse arthritis, as evidenced by significantly greater cartilage volume loss when compared to placebo. So there's actually quite profound negative effects. And so, well, some people start asking the question, okay, so we start seeing decreased volume loss in people who get cortisone injections. Is this actually clinically relevant? And the answer is yeah. So this was published in the Bone and Joint Journal 2 years ago, and they say corticosteroid injections seem to be associated with an increased risk of knee arthroplasty, which is a knee replacement surgery, in patients with or at risk of developing symptomatic arthritis of the knee. These findings suggest that a conservative approach regarding the treatment of these patients with steroid injections should be recommended. That was followed up with 2 additional studies, both of these published in late 2021. And the first one concluded, this study documents an association between hip steroid injection and rapidly destructive hip disease, which is a extremely aggressive formation of arthritis. This other study found that 7% of people who underwent imaging-guided intra-articular steroid injection developed rapidly progressive arthritis of the hip. And that is very high. This is one of my patients who unfortunately kind of saw this in the knee, right? So on the left, this is a picture of the x-ray of this patient's x-ray in October 2020. And you can see the medial aspect of the knee has about grade 1, grade 2 osteoarthritis. She did not have any prior knee pain. She had a steroid injection, and then just 1.5 years later, she is now grade 3, almost grade 4, and is contemplating a knee replacement surgery because of how progressive her arthritis is and how bad her pain is. And so, cortisone injections have profound negative effects on joint tissue, and it accelerates the formation of arthritis, and people seem to have worse outcome, and they need to end up with a joint replacement surgery. Now, what about steroid injections' negative effects on soft tissue? So the whole concept of using cortisone to treat tendon disorders, right, what we call tendinitis, it's meant to treat the inflammation associated with tendinitis, right? So you have all these conditions, right? So rotator cuff tendinitis, which implies inflammation of the rotator cuff, lateral epicondylitis, which is tennis elbow, or medial epicondylitis, which is golfer's elbow, which implies an inflammatory disorder affecting the tendons in the elbows, patellar tendonitis, Achilles tendonitis, trochanteric bursitis. All of these imply an inflammatory condition. And that's where the naming really affects treatment, right? If we call it tendinitis with the itis part in Latin meaning inflammation, that affects how we treat, right? Then it makes sense to use an anti-inflammatory medicine like cortisone to treat these conditions. So this study was published in the Journal of Bone and Joint Surgery in 2005. This was a long time ago. And what they said at that time was that most clinicians still use the term tendinitis, thus implying that the fundamental problem in tendon disorders is inflammatory. And they actually say, we advocate the use of the term tendinopathy as a generic descriptor of the clinical conditions in and around tendons arising from overuse. And they say this because histological examination of tendinopathy shows disordered haphazard healing with an absence of inflammatory cells, a poor healing response, non-inflammatory intratendinous collagen degeneration, fiber disorientation and thinning, hypercellularity, scattered vascular ingrowth, and increased interfibrillar glycosaminoglycans. Frank inflammatory lesions and granulation tissue are infrequent and are often associated with tendon ruptures. And so the takeaway from this is when you look at tissue under a microscope, there actually are no signs of inflammatory cells. There's actually no underlying inflammation in these disorders. So then you start to ask the question, if there's no signs of inflammation, should we still be using steroid injections to presumably treat inflammation, right? And so let's ask what our dermatology colleagues say about steroids. So we all know that they use steroid injections to treat keloids. And when you ask about, well, how do steroid injections actually treat keloids? They work by suppressing inflammation, right? That makes sense. They inhibit leukocyte and monocyte migration and phagocytosis. They reduce the delivery of oxygen and nutrients to the wound bed. They inhibit keratinocytes and fibroblasts and slow reepithelialization and new collagen formation. And they may reduce plasma protease inhibitors, thus allowing collagenase to degrade collagen. And you start to ask the question, what are tendons composed of? Tendons are composed of collagen. And we just learned from our dermatology colleagues that cortisone restricts delivery of nutrients. It slows down the formation of new tissue. It increases tissue degradation and damages collagen. And so you start to think about these effects and wait, won't steroids actually damage the tendon based off of what we know? And so this was actually studied, right? And this was published in The Lancet in 2010. efficacy and safety of corticosteroid injections and other injections for management of tendinopathy, what they found was we showed consistent findings between many high-quality randomized controlled trials that steroid injections reduced pain in the short term compared with other interventions, but this effect was reversed at intermediate and long terms. This is a landmark meta-analysis in that it presents high-level evidence that cortisone injections are harmful in the long-term treatment for tennis elbow. And so we start to really ask the question, are cortisone injections truly a gold standard form of treatment, or should we do what we learned first in medical school, which is do no harm, right? And this is, again, where the naming convention affects how we treat certain conditions. We are trained during medical school and residency that shoulder pain is rotator cuff tendonitis, that tennis elbow and golfer's elbow is lateral epicondylitis, and that implies inflammation. And when we have inflammatory disorders, we can treat them with steroids. But the problem is, we now know that these are not inflammatory disorders. We need to question the naming convention. So we should actually be calling all of these things tendinopathy. So instead of rotator cuff tendonitis, say rotator cuff tendinopathy. Golfer's elbow and tennis elbow should be common extensor tendinopathy and common flexor tendinopathy, patellar tendinopathy, Achilles tendinopathy, gluteal tendinopathy. And when you switch over to these naming conventions, you take away the term, the inference of inflammation. And when you take that away, then you no longer will default to saying, oh yeah, a cortisone injection is what's going to help this patient's pain. So if we have tendinopathy, and now we know that steroids can cause harm, what else can we use to treat tendon disorders? And that is the whole foundation of why we are looking into other types of treatment options, specifically the orthobiologics and specifically PRP, as well as stem cells. And so I want to spend some time just first talking about what is the basic science? Like, why does this work, right? So if you just stop and think about what happens when you have an injury, right? You got a laceration on your arm or your skin somewhere. There is an injury, right? You have damage to tissues, you have damage to blood vessels, and you go through this, your body goes through this very complicated cascade that results in tissue healing and tissue remodeling, right? And so the thought process behind the biologics is, can we use this complicated cascade of healing, put it into a syringe, and then inject it under imaging guidance into a joint that is arthritic, or into a tendon that has tendinopathy, which that has wear and tear. And the goal is to use the body's own capacity to decrease pain and decrease inflammation, and also to improve the biochemistry of an injured area. And when we look at that the results seem to be pretty good, right? And so what options do we have, and what kinds of biologics are there? There are many different types, but the two main types that have really got traction and has support from clinical trials is PRP, or platelet-rich plasma, as well as mesenchymal stem cell injections. And there's two types of mesenchymal stem cell injections, what we call MSCs. There's bone marrow and there's adipose tissue. And I want to talk about those first. So what are mesenchymal stem cells, or what are MSCs? MSCs are found in pretty much every type of tissue, right? You can get it in fat, bone marrow, skin, heart, muscle, liver, neurons, kidneys. They essentially sit on blood vessels. And they have a lot of different roles. They have a role in immunomodulation. This is what prevents autoimmune diseases, trophic effects, pain relieving effects, as well as long-term potentiation of the other three roles. And so in terms of orthobiologics and what we use MSCs for in orthopedics, it's really these bottom three: the trophic effects, the pain relieving effects, and the long-term potentiation. So what are the trophic effects of MSCs? So they stimulate angiogenesis, they stimulate mitosis, it inhibits scar tissue formation, and it inhibits ischemia-induced apoptosis, right? So when you compare the effects of MSCs and compared to cortisone is the exact opposite of all of these. It actually breaks tissue down. And now you have the MSC effect, which is the trophic effects actually stimulating tissue healing. All of this results in tissue remodeling and tissue healing. What about pain? MSCs are incredibly effective at reducing pain, mainly because they produce peptides that activate opioid receptors. And so this is the main pathway for pain relief. And the reason why orthobiologics are so effective is because not only do they relieve pain, but they have long-term potentiation. And so it's not just like taking ibuprofen where you get pain relief, but then the effects wear off. You actually get long-term potentiation, right? Studies consistently show that orthobiologics provide long-term pain relief. And so you can see in this chart here that corticosteroid injections or steroid injections, they start to wear off at about 6 weeks. And, you have pain relief for 6 weeks and then it starts to wear off. Whereas on the right-hand graph, the effects of PRP just continues to go up and up and up. And that's because of this long-term potentiation. So how does that work? So you have MSCs, they do their thing. They have the trophic effects, they have the pain relieving effects, and then they're phagocytized by monocytes. Monocytes help potentiate the effects of MSCs, and this results in long-term potentiation. And this is incredibly important, right? And so you're like, wow, that sounds amazing. So how do we get these MSCs? A lot of different ways, and these are the most common ways. So you can harvest them from bone marrow, and the most common place when done in the office is from the iliac crest. You can get them from adipose tissue, adipose being fat tissue. So a lot of people really actually like this option, right? You get it from their abdominal cavity. It's kind of like a mini liposuction, or you can also get it from the buttocks. The other way of getting it indirectly is through platelet-rich plasma. So what is PRP? PRP is technically defined as any plasma solution with a platelet concentration that is over whole blood baseline. So what does that mean? That means anywhere between 1.5x to 30x, or potentially even higher, right? It's just concentrated platelet-rich plasma. We still don't know what the best concentration is, but what we do know is if you don't have enough platelets, well, then you don't have enough platelets. If you have too high number of platelets, that could be potentially detrimental to your tissue. And so we're still studying what the best concentration of platelet is, right? But it's very important that the number of platelets matter, and we'll kind of talk about this later, because all of these are what helps control tissue healing, tissue remodeling, and tissue proliferation. And it's just like when you take blood pressure, right? You can't expect a lower dose of a blood pressure medication to have the same effects of a higher dose of blood pressure medications. It's just a different concentration, right? And so the same thing affects that if you're not using enough platelets, you may not get as big of an effect. So how do platelets work, right? When platelets degranulate, and when you draw someone's PRP, they have an incredible amount of growth factors that are just circulating around in your body, right? And all of these growth factors you can see here, VEGF, PDGF, TGF-beta, FGF, EGF, IGF, HGF, all of these play a different role, right? All of these are super important in angiogenesis, cell migration, cell differentiation, cell proliferation, collagen synthesis, tissue matrix formation. Specifically these three, the platelet-derived growth factor, TGF-beta, and fibroblast growth factor, these have actually been shown to activate MSCs. And so this would be an indirect way of activating mesenchymal stem cells to do their thing, to do their effects, to get all of their beneficial effects. So this article was written by Arnold Kaplan, and he says a bolus of platelet-derived growth factor would have a profound effect on the resident mesenchymal stem cells, and this could account for the decreased pain and inflammation experienced in osteoarthritic joints exposed to PRP. So that's kind of the science of why and how platelet-rich plasma injections work. Now let's look at the clinical trial data. Let's say real-world data. Does this actually help people in their painful conditions? So you ask the question, do they work? And the answer is yes, for many conditions, but not all. And so these are the indications where there are multiple level 1 studies, where there are systematic reviews and meta-analysis showing benefit of PRP in these conditions. So knee arthritis, extremely well studied. Tennis elbow and golfer's elbow, extremely well studied. Gluteal tendinopathy, plantar fasciopathy. So what I want to do is I want to use knee arthritis as a case study. Now I can do this with all these other conditions, but knee arthritis is extremely common and it is by far the best studied. So what is the evidence for the use of orthobiologics in knee arthritis, especially when compared to steroid injections, right? We already discussed earlier that steroid injections can cause harm. It can increase the risk of arthritis. It's not even as good as physical therapy in controlling long-term pain. So what is the use of PRP and what is the evidence for stem cells? So let's first talk about stem cells again. Let's compare bone marrow versus adipose mesenchymal stem cells, which one is quote unquote better for the treatment of knee arthritis? This was published in the American Journal of Sports Medicine just a few months ago. Intra-articular injections of mesenchymal stem cells for knee arthritis. This included 19 studies in their systematic review and meta-analysis. And what they found was intra-articular injections of mesenchymal stem cells without any adjuvant therapies improves pain and function for arthritis. Significantly better outcomes were obtained with the use of bone marrow MSCs as compared to adipose MSCs. So according to this systematic review and meta-analysis, both of them actually worked, but bone marrow actually did better than adipose stem cells. So, okay, what about PRP versus stem cells? If we know bone marrow is better than adipose tissue, is there a study that compared bone marrow to PRP? And the answer is yes. This was published very recently in the American Journal of Sports Medicine. Bone marrow aspirate concentrate is equivalent to PRP for the treatment of knee arthritis at 2 years. They found that both groups had significant improved IKDC and WOMAC scores. Those are functional scores for arthritis from baseline to 24 months after the injection. This was only one injection. They compared one injection of bone marrow stem cell and one injection of PRP. And they conclude for the treatment of arthritis, PRP and bone marrow concentrate performed similarly out to 2 years. Bone marrow stem cell was not superior to PRP. What about cost? Stem cell injections are incredibly expensive, on the orders of thousands or tens of thousands of dollars. PRP down into the hundreds. And so when you do the cost-benefit analysis, PRP is significantly cheaper, but it works the same as stem cell injections. So then you start asking the question, how does PRP compare to everything else that we're doing for the treatment of knee arthritis? And so this was published in Cartilage. This was also just a few months ago. PRP injections for the treatment of knee arthritis. This is a meta-analysis of 34 randomized controlled trials. And they conclude the effect of PRP goes beyond its mere placebo effect, and PRP injections provide better results than other injectable options. And these, they compared steroid, they compared hyaluronic acid, they compared placebo. They say this benefit increases over time, right? Remember, steroids decrease over time. They say being not significant earlier follow-up, but becoming clinically significant after 6 to 12 months. And this is what we know, right? When you have a laceration on your skin, you don't have brand new skin right away. That takes time. It takes a few months, but then you have brand new skin and it doesn't hurt anymore. And so PRP is the same way. PRP, you're playing the long game. It becomes clinically significant after 6 to 12 months. People do significantly better after PRP injections. Does PRP affect arthritis progression, right? So we know it can help treat pain and symptoms, but does it affect arthritis? Does it affect the biochemistry of the joint? So this was published just a few months ago, 2 months ago, intra-articular injection with platelet-rich plasma compared to steroid injection or saline solution for knee arthritis. And what they found was for the WOMAC function, the PRP group and steroid group were superior to saline group, but the PRP group showed the lowest radiographic progression of arthritis at 1 year of follow-up. They found that the people who get the PRP injection had less progression of their arthritis. This was study was titled Platelet-Rich Plasma Injections Delay the Need for Knee Arthroplasty. So not only does it delay the progression of arthritis because people's pain and symptoms are much better controlled, they don't need a knee replacement surgery. These authors conclude this study suggests that the application of PRP in knee osteoarthritis patients is a treatment that could delay a knee replacement surgery. Now, of course, they kind of comment, more studies are needed to understand and improve this therapy. But this is not the only study that said this. There are more and more studies that are looking at PRP and looking at the long-term effects of PRP treatment for knee arthritis. And so it's really important to understand that the way we think about arthritis needs to change, right? Arthritis is no longer something that we tell patients, just deal with it until you're ready for a knee replacement surgery. We need to start thinking of it. We need to start to think about it as a chronic progressive disease that needs to be actively managed, just like high blood pressure, just like diabetes, just like high cholesterol, obesity, right? We need to actively manage these diseases. What we know with hypertension, high blood pressure, is if left untreated, there is cardiac remodeling that results in left ventricular hypertrophy that results in heart failure, right? What we know about arthritis is that if it's left untreated, it gets worse. And when it gets worse, people end up needing a knee replacement surgery. And that has profound effects on quality of life, right? And so how does this work, right? So Arthritis is defined as cartilage destruction. It's the gradual wear and tear of cartilage. And when you lose cartilage, right, you release a lot of these proteases. These proteases cause inflammation within the knee joint, so it activates inflammatory cells. Inflammatory cells release inflammatory cytokines. Inflammatory cytokines continue to weaken the rest of the cartilage, which results in cartilage destruction. And so you just get this cycle, right? And this is why arthritis, when left untreated, is progressive. It gets worse unless you do something. So what is PRP's hypothesized role in managing arthritis? Well, number one, it's to treat pain and decrease symptoms, right? After all, that's what matters. That's what prevents people from exercising. That's what prevents people from moving, is because of pain. So PRP will decrease pain. But more importantly, it helps change the biochemistry of the arthritic knee. Remember, PRP contains an incredible amount of growth factors. And what these growth factors do is it puts an end to this cycling, this progression of the arthritis, right? It decreases the concentration of proteases, which will then decrease the amount of inflammatory cells, which then decreases the amount of inflammatory cytokines, which then preserves, or at least tries its best, to keep the cartilage healthy. It stops this progression. And so what we're learning from all of these studies is, for the treatment of knee arthritis, PRP results in better outcomes and less pain. And again, that was just knee arthritis. We can go through the same explanation for tendinopathies and soft tissue, but we won't do that here, because I really want to spend some time on talking about that not all types of PRP are the same, right? There's different types of PRP. Do you have a leukocyte-rich or a leukocyte-poor PRP? Do you have monocytes included in your sample? What is the platelet concentration? What is the method of injection? And I kind of want to frame this discussion with this very recent study called the RESTORE trial. This was published in JAMA just a few months ago. And let me just read the conclusion first. Among patients with symptomatic mild to moderate radiographic knee arthritis, intra-articular injection of PRP compared with injection of saline, so placebo, did not result in significant difference in symptoms or joint structure at 12 months. These findings do not support the use of PRP for the management of knee arthritis. And this was the first study in a while that showed that PRP injections actually did not work and did not show improved symptoms when compared to placebo. But again, this is where the importance of not all PRP is the same. Platelet concentration varies, cell content varies, growth factor content varies. And the reason it matters is this is the PRP they were using. And I circled the two most important things here. Their platelet concentration was 1.6x. Now, this is actually from the manufacturer's website. So you can kind of inference, well, if the manufacturer is reporting 1.6x platelets, chances are it's anywhere between 1 to 1.5. It's probably lower than that. And the same thing with monocytes. They essentially have no monocytes. And kind of earlier in the talk, we discussed why monocytes are so important. They help with long-term potentiation, right? So platelet counts matter, right? Again, going back to that high blood pressure, you can't expect a low dose medication of, for example, a blood pressure medication to have the same effects of a higher dose medication. And so this is probably why they got the conclusion that they did not find any significant difference between PRP and placebo at 12 months. However, this was their conclusion. They did not write this part, which is their secondary outcomes. And so despite using PRP with lower platelet counts, this is one of their secondary outcomes. The number of patients in the PRP group who reported global improvement overall was statistically significantly greater than in the placebo group at 2 months and 12 months, right? So even though they used a kind of lower platelet count, they still had benefits. And when you kind of look at it, well, those benefits are still better than the side effects of steroids. And chances are, which is what we're seeing with all these other studies, higher quality PRP and better platelet concentration likely leads to better outcomes. So we can't just use the cheapest form of PRP, but even when they did use the cheapest form of PRP, their secondary outcomes were still better. People who got the PRP injections, their global improvement overall was still better. Again, this is kind of a slide of just summarizing what current clinical trial data is showing for the use of PRP, where knee arthritis, elbow tendinopathy, gluteal tendinopathy, plantar fasciopathy, excellent results. Rotator cuff pathology, so rotator cuff tendinopathy and partial tears of the rotator cuff, more of the recent studies are actually showing excellent benefit. And then kind of lagging behind, where we're still not sure why, but these conditions are they're just very difficult to treat. Achilles tendinopathy and patellar tendinopathy, where you still have weak or conflicting evidence for the use of PRP. These are those study data, and you can feel free to look through them on your own. And with that, I will take any questions. And if you're looking for more information about the use of PRP in specific conditions such as tennis elbow, plantar fasciopathy, gluteal tendinopathy, or knee arthritis, check out my orthobiologics playlist in my YouTube channel. Thanks for watching.